Hello, everyone. Welcome to Asia Novel Seminar hosted by Asia. This is the fourth episode of Season 2. In each episode, well-known experts have been invited to discuss training topics in arthroplasty. The Asia hope to establish a professional arthroplasty forum that joint surgeons from all over the world can be connected to share their personal ideas, clinical experience, and cutting-edge techniques in order to solve clinical challenges and improve the development of arthroplasty in Asia. I am Dr. Chai Wei from Chinese PLA General Hospital in Beijing. It is my honor to moderate today's discussion. It is also our privilege to have well-known expert with us today, Dr. Seth Jarabek from Hospital for Special Surgery in New York, United States. Let's welcome Dr. Seth Jarabek to briefly introduce himself. Let's welcome.
Hello. Yes. Hi. Thank you, Chai, for the introduction. So, I'm Seth Jarabek from New York. Work at the Hospital for Special Surgery. We're a high-volume joint hospital in New York. And it's been a pleasure getting to know Chai Wei and his colleagues over the years. I've visited China many times as Chai Wei's visited us, and we've talked a lot about robotics and different techniques. And today we're going to talk about robotic hip replacement. I'm going to be introducing the topic, and then Chai Wei is going to be showing or demonstrating some complex cases and how he finds value.
Actually, Dr. Seth Jarabek is my very, very good friend. And we both visit each other many times. And he also have very experienced surgeon in Mako assisted surgery. And he's my teacher, taught me quite a lot, especially in the designing rationale and how the machine work actually. And we operate together either in New York or also in 301 Hospital. And so today we are very lucky to talk to each other and learn each other again. And I have to say, previous in Asia Novel Seminar, we discussed multiple subjects around total knee, like varus knee, valgus knee, flexion deformity, kinematic alignment, total knee, two-stage revision, one-stage revision, challenging briefing TKA. In this episode, Dr. Jarabek and I would focus on the hip arthroplasty, especially the Mako robot assisted surgery. So actually, the Dr. Jarabek is also one of the designer of this robot, and also one of the designer of the robot software. So he knows quite a lot about this robot. So let's welcome Dr. Jarabek to give his topic.
Yeah, so I'm going to be talking about just introducing the topic of robotic hip replacement. So kind of what it is, and we can talk further about that during the discussion, but I'm just introducing the topic. And then Chai Wei is going to be, I think, sharing some complex cases in China that they definitely you guys get a lot of cases that we don't always see in the United States. As you said, there are some relevant disclosures for me. I do get consultant. I do get royalties from Stryker, primarily because of my input on intellectual property surrounding robotics. As a background, again, I did 2 fellowships. I'm currently on staff at the Hospital for Special Surgery and have my academic appointment at Cornell. Did 2 fellowships. One at the Hospital for Special Surgery and Joints, and then one back at Harvard, where I did my residency in sports medicine, but I do primarily joints these days. Thinking about hip replacement, a lot of people say, why do you need advanced technology? And we're not as accurate as we think we are. This was actually done, this study was done at Massachusetts General Hospital when I was actually a resident. I didn't participate in the study, but I thought it was interesting to show that even though the surgeons were very high volume, excellent surgeons, they didn't really get their cup position accurate all that often. So when you looked at it, and we've seen this as the 1,800 hips, And they thought that they could be, roughly at 35 or 40 of abduction and then roughly at 15 to 20 of anaversion. And they thought that they were going to be a bit better, but only about 50% of the cups were in that zone, what they felt was a safe zone. So even master surgeons didn't get their implant, particularly the cup, where they wanted to, about 50% of the time. And there were things that kind of influenced that: surgical approach, BMI, volume, but nonetheless, these were all high volume surgeons. The other thing that we don't do all that well is hip length or leg length. And in the United States, it is a common reason why people actually sue their physician. So in the United States, if somebody's unhappy, they can get a lawyer and actually have you sue their surgeon for monetary reimbursement because of poor practice. So in the United States, hip length discrepancy or leg length discrepancy after total hip is the number one reason why surgeons are sued. And when you look at it in general, about 29% of the time, 28 or 29% of the time, the surgeons in the United States are off by up to a centimeter, either too long or too short. And that's kind of unacceptable these days in the United States. And robotic hip has basically been validated plus or minus 3 millimeters, so much tighter control. So what is a robotic hip? So a robotic hip starts with a CAT scan. So you actually get a CAT scan ahead of time and then do some three-dimensional modeling or planning. And you do that with the software. And then what happens is that you have a robot, like a Mako robot that we were talking about, that it has a hand piece and a reamer. And then you can prepare the bone with that reamer. And then you can place the cup, and it controls the cup position, controls where your hip center is, as well as the position. So with the hip center, it's a three-dimensional process, and then also the orientation of it for the abduction and anaversion. I'm going to show some short videos demonstrating this. There are two different workflows. One would basically just put a single array onto the pelvis. So you actually do your planning. You put an array on the pelvis. You do what's called registration. I'm going to demonstrate that. And then you ream, and then you can place your components. You still get hip length and offset basically by a checkpoint on the greater trochanter. There's also an enhanced workflow where you can put an additional array on the femur. And I've been doing more of these recently just because we're studying some of the accuracy of it, but it does give you additional information on the femoral side. What I'm demonstrating today will be the the express version. So the preoperative planning, you basically see everything in 3 dimensions. In this case, there's 11 degrees of anaversion on the femur. And then you can scroll up and down and actually look how the femoral component will fit within the bone. So you can get the size right. You can get the offset correct. And then you can also look at the acetabular component and how that fits within the patient's pelvis or bone. Look at the orientation. This one happens to be at 4220. Make sure the anterior portion of the cup is kind of tucked underneath the bone. So you can scroll through in 3 dimensions and look at it in different ways in all 3 dimensions. So that way you get more accurate sizing, more accurate placement. You can see what you're doing with the leg length and the offset. So for here, we plan to be about 2 millimeters longer and decrease the offset by 0. And again, you can compare it to the contralateral hip as well, where we're 1 shorter and similar offset. So that's all the pre-plan. And then we go into the operating room and we place the array. So you have to start out, I did the surgical dissection here, but then before you dislocate the hip, you need to put an array on the pelvis. So this is an array. There's 3 pins that you place right in the iliac crest. And so you have to be accurate with getting those into the crest so the array is stable. So there's 3 pins and just place them as such. You tighten the clamp, and then now there's a pelvic array on the pelvis. This is that checkpoint in the greater trochanter, and this is me registering the hip length to start. So you register the hip length and the offset, and then as well as the pelvis. So the acetabular registration, you take basically several points from around the pelvis to register, because in the beginning, the robot doesn't know where the patient is in 3 dimensions. So we have to tell the robot where that pelvis is in space. And so we do that by taking multiple points from around the acetabulum. And that's the process of registration. So that's why I'm taking these 34 points here from around the pelvis. And then the robot will know where that patient is in space. And then we can start to prepare the bone. This is what's called verification, where we just double check to make sure that our registration was accurate. And then we can start to prepare the socket. So we have a reamer, as you can see here, and then you actually get some visual feedback from the software. The green is the volume of bone that we will be removing. So we'll be using this reamer to remove bone, and you'll actually see that the volume of green starts to disappear. And that's when you know you're getting towards your desired hip center. And you can actually see the numbers here, how it goes kind of 0, 0, 0. That means that we got our hip center where we wanted it to be. And then we can do the acetabular impaction. So at this step, now our reamer has removed the bone, and I single ream everybody. If it's a 54 cup, I single ream with a 54 reamer. That's where I save some time. And then I put the impactor onto the robot. So there's kind of this assembly where you put these 2 pieces together. And then once the robot is kind of activated or locked in, it'll secure and orient the cup exactly where you planned. So as of right now, you can see that now the robot arm is holding that. And even if the pelvis moves, the robotic arm will follow the pelvis. So it keeps that cup at 4220 as I'm impacting it. And then you'll see that it'll tell you how many millimeters proud you are. So as I impact it in, it'll start to get seated. And once we're seated, then you can remove the arm from the cup. Femoral preparation is very similar to what you would do manually. In this case, this happens to be an Accolade 2 blade taper stem. And so we're just broaching up to whatever size it was, a 5 or 6. And then once you get your desired size and the appropriate stability, then you can actually do a trial reduction and get your leg length and offset. So once it's prepared, then we can actually reduce the hip. So I've reduced the hip, and then you take the 2 points, a point off the trochanter, a point off the knee, and it knows where that femur is in space. And you can see that I've lengthened 1 millimeter and increased my offset 1. So very similar to what I was planning. Compared to the contralateral hip, I was 1 millimeter shorter, 1 increase in offset. So it just shows how accurate this is. And my plan was essentially very similar to what I executed, because I planned to be 2 millimeters longer and the offset was going to be 0. So very close to that. So that's something that is very reproducible. And the fellows who train at HSS, almost everybody, as they leave, are very excited about this hip application and use it in practice. Looking at the accuracy, I've done studies, other people have done studies looking at this, but this is a study that we did with a CAT scan, 20 patients with postoperative CTs. And basically the cup position was accurate by, within 1.5 millimeters in the medial lateral, AP, and superior inferior positions. Cup orientation was always accurate within about 3 degrees. Reduction results, leg length, 1.6 millimeters plus or minus 1.2. So pretty tight tolerances. Offset also 1.3 millimeter accuracy. Stem version. So this one was one where I'd measure the stems, and those were accurate to 1.8 degrees. And combined anteversion to 3 degrees. So very accurate, much more accurate than manual techniques. And then there are other papers too looking at this. So I'm not the only one who's done studies on this. Ben Dome has done several studies, and others who have looked at leg length, who've looked at accuracy, and everybody has a very high correlation, or very accurate. So I'm going to show you just a quick case example or two. These are the first 2 cases that I had done robotically. So this is what really got me interested. This was a case that, patient clearly had some arthritis in the head, but also had kind of subchondral fracture that collapsed and some erosion of the acetabulum. And the reason why I used it is when I was templating, she was a lady, and it was a 56 millimeter cup. And I said, oh, maybe I won't have enough room, anterior or posterior, to fill that void. And so I got a CAT scan to make sure that, that I wasn't going to be violating the anterior or posterior columns. And then so I got my CAT scan, and actually the 56 millimeter cut fit her very well. And it gave me a lot more confidence that I wasn't going to take away her anterior posterior column. And so this is, again, like I said, one of the first cases I used with the robot, and I planned in 3 dimensions. And then once we planned it, you get this simulated X-ray view. So basically where the cup is, where the stem is. And then after surgery, that was my real implant, and was able to equalize her leg lengths. And then again, if you look at it, I guess I left my stem in a little bit of varus if you're critical, but the cup looks very similar. You can see how I have a screw in there. So very similar outcome. And then the next case I did with it was this one. Also, I was planning to get a CAT scan to look at the anterior and posterior columns, figure out where the hardware was. In this case, a post-traumatic hip where I couldn't even really see it, and distorted anatomy. I think that this one really kind of showed me the advantages of robotics and CAT scan planning. So with the CAT scan, I was even able to identify a screw that I wanted to remove, and I only needed to remove that one screw. The rest of it could stay. I was able to prepare the cavity, plan for the stem. Now you can see these large osteophytes. Again, this is the robotic kind of pre-plan. And then this is what I actually executed during surgery. So it is pretty remarkable that you could plan in such a way and execute the surgery in such a way that's very reproducible. So in general, I do find the accuracy of the preoperative planning using the CAT scan is very powerful tool. The robotic arm, as you see, assists with the acetabular bone preparation as well as the cup impaction. And then for the femoral stem, we manually prepare it. The express workflow that I showed gives you the leg length and offset. And enhanced, we can also give you femoral version if necessary, or if you prefer that pathway. And like I said, they're very accurate regarding cup and stem position. And then I find that it makes cases such as dysplasia, post-traumatic, much easier. Anything where the anatomy is distorted, I think it really shines. The one thing that I do have to say is that there are some limitations, and the limitation is the expense. There are additional costs of the robot, the CAT scan, as well as disposables. So that's something that we have to figure out if it's justified or valuable. But in general, I do find that these cases are very efficient. They don't take me any longer than a standard hip replacement, and I get a lot of value from the 3-dimensional planning and execution. So thank you. That's the introduction to our robotic hip replacement.
Yeah, thank you. Great lecture. So I listened very carefully and learned it again. Thank you. So I'm going to talk about some complex cases. So my topic is Mako Robotic assisting complex hip arthroplasty. I'm Dr. Trivey from Beijing. So current now I have done 800 hips. Most of them they are complex cases, hips. So till now I don't have we have no dislocation, loosening, or revision till now. The first 855 THA by Mako. Talk about the robot, I have to talk about the learning curve. This is my learning curve, because I start to use the Mako robot from the primary hip, and we don't select the patient. We start from our normal clinic. So the one surgeon's first 100 cases of robot assist THA, observed operating time, cup positioning, LD offset robot complication, and Harris score. follow-up for 3 months. Use the Cosmo analysis to calculate the learning curve. The operating time skin to skin is 95 plus minus 15. The minimum is 8 minutes. The longest more than 2 hours. So the 14 case was the turning point. So after 14 case, operating time was stable. So according to the groups, whatever 1 to 15 or 15 to 100 cases, no difference in cup positioning, safe zone ratio, LOH complication, etc. That means the robot is kind of very, very stable. So no matter the time you get used to, and then you still have a very stable result. The learning curve of the complications, we don't have a unacceptable complications during the learning curve. So the proficiency on time is less than 10 cases. So one surgeon showed the results. The Levenik safe zone by robot is 91. The manual is 82. The inclination, the robot did 41 plus minus 3. By hand used 40 plus minus 6. That shows the using hand shows some difference. The anti-version looks very similar. So in conclusion, it takes one surgeon 14 cases to be proficient in robot-assisted THA. So pretty quick. As Dr. Jarbeck mentioned, the fellows will love the robot-assisted surgery. They will learn the very complex THA very soon. They will have the face to do the total hip surgery. The limitation of this study is retrospective study and the simple size. The measurement was based on the X-ray. The single surgeon's learning curve may not be applicable to other surgeons. But as we mentioned, Dr. Sack mentioned the same. Our fellows, they like to use a robot to correct their surgery. Let's talk about some of the complex cases. The first topic is the robot-assisted THA for Chrome 4 DDH operating procedures. This is our normal case in China, as Dr. Jarbeck mentioned, not a very popular case in US or in New York, because our country is kind of a developing country. We still have quite a lot of these cases. It's both bilateral Chrome 4 DDH patient. So by Mako, you can have a 3-dimensional reconstruction model in Mako. So you can see the dislocation is kind of high. Then you will get the CT landmark selection. The beauty of this robot system, you can talk to the engineer to position the ASNS, the posterior acetabulum, anterior acetabulum, superior acetabulum, and the rotation center. And you can interact with the robot and with the engineer to put the landmark exactly right. So the ASS in some DDH patients were electable due to the previous hip surgery. So sometimes you put the wrong ASS may change the anteversion and the inclination of the cup of the base patient. So 3-dimensional preoperative plan in Mako is very important in this kind of patient. You should check the coronal version, sagittal version, cross version. Then by Mako, you can see to check the size of this cup. Because it's a DDH patient, the acetabulum was not developed. It's very, very small. In old time, where we put in a 42 or 40 cup. By Mako, you can put it as larger as possible. To put a large cup and you try to use a large head. Then you get a good rotation center and try to get a good leg length. So during surgery, you have to dissect and find the true acetabulum. So before do Mako surgery, you have to know how to do a Chrome 4 DDH because the Explorer is still difficult. So when you locate the true acetabulum, then you do the registration helped by the Mako system, and then ream the acetabulum by Mako arm. This is the explorer. The explorer is the same as you don't have Mako the same. This is the restoration part. So you have to detect the anterior, posterior, and superior acetabular, match the original CT landmarks, restore 32 points around to outline the acetabular ring. Do not remove the osteophytes before the restoration. Some restoration points cannot be touched when located behind the osteophytes. Overall accuracy is 0.2 millimeter, critical in complex cases. So in my experience, you don't want to have any red points. If you have any red points, you should re-registration this patient. The overall accuracy sometimes is not as accuracy as you expected. So by the robot arm could limit the operating range 2.3 millimeter. Sometimes it needs to be deeper properly because this chrome 4, the cup we want to middleize a little bit. A single reaming could avoid the manual multiple ream to protect the acetabular ring. They remove all the green area by reverse reaming. Red area means reaming plus 1 millimeter. Black area means penetrating the acetabular floor. Maintain the acetabular ring intact is virtual for cup initial stability. Then cup listening and the final check. Clean all the soft tissue and the bone debris in acetabulum. Gently impact just I think it's 1/3 of the euro strength, as the cup is very fragile and you don't want to make the pelvic discontinuity because the cup is very big for this kind of patient. Implant the cups in plant depth and angle by Mako inclination. More than 2 screws must be used. Polyethylene liner direction was dependent on the hip stability. Ensure initial stability. Sometimes we should use the modular stem because the original Acetabular 2 stem cannot change the anteversion. So we use quite a lot of atrium stem for this kind of patient. Sometimes without STO, so relatively short dislocation distance, relative normal proximal femur, so fully soft tissue release, powerful and experienced assistant to help you to reduce the hip. Most of the time for crown 4 DDH, you need to do the sub-troch osteotomy, so 2 millimeter below the lesser troch. The timing is unable to reduce after sufficient soft tissue release. So do the transverse osteotomy. The length is depend on the length and the leg length and the reduction difficulty. Additional fixation where titanium cable or bone plate. So marrying the hip length and offset, this is very important part. When we marry, it's just the hip length, not the leg length. So absolute femur and tibial length, you should before surgery have known with the 3 feet of film. So we have to counting the osteotomy length. The pelvic tilt and the spinal flexibility will help to know how much pelvic can be reduced in the future. This is the post of X-ray. Look at X-ray. Look at the acetabular side. In the old time, when we use manual, we cannot have this very stable cup. We cannot have looks exactly the same positioning cup. The Mako can help you to have this another case, very similar case. This show the distance. It looks like showed like the 85 different of the hip length, but actually the true leg length does not like this because you have to counting the subtroch osteotomy, how much length you have resect. This is the well coverage of this patient, use 46 cup. You can imagine in the old time, this cup is very big. So we have the preliminary result: 27 cases of robot assist THA for Crohn 3 and 4 DDH. The match with conventional THA at 1:1 ratio, the age, gender, BMI, etc. Compared cup positioning and the clinical outcome between groups. This patient characteristic between two groups is very similar. This is the result. So the inclination of the cup for conventional THA and the robot THA was very similar. The anti-version of the cup for conventional THAs was significantly greater than the robot part. The robot is much more accurate than the hand anti-version. The ratio of the Acetabulum cup in leavening safe zone was only 37 by hand in conventional THA and 96 in robot THA. In the robot, THA achieved better leg length discrepancy than that conventional THA. There was no difference in Harris score between groups at 3 months follow-up. No dislocation occurred in all cases at the 3 months follow-up. So our experience on conclusion, the robot assist THA for patients with high dislocation improves the accuracy of cup positioning with respect to safe zone. Further postoperative studies are required to evaluate whether better cup positioning will improve clinical outcomes in the long-term follow-up. So Mako robot assist for the DDH patients is kind of a good tool for, especially for fellows, young surgeons. In old time, people don't dare to touch this group patient. Now it's become easy. There are quite a lot of similar cases. And as Dr. Drebeck mentioned, for the complex OA patients, DDH, traumatic OA, etc., this with screws, then the Mako can help you to avoid the screws and put the cup in the right position, rheumatoid arthritis, with the protrusion of the cup, Acetabulum, and put the cup in the right position. And also we have done some work by Mako for the fused hip. So our study in robot assist total hip arthroplasty for fused hip. So one surgeon DHA for AS patient with hip fusion in extended positioning. The 19 robot assist THA was 37 manual THA, operating time, cup positioning, LLD offset, etc. So this is a typical patient in our clinic. So regarding the fused acetabulum and the femur as a whole, mapping the bony boundary to construct the three-dimensional model. As mentioned, we discussed this kind of patient with Dr. Drebeck quite a lot because he knows where to put the restriction point in this kind of patient. And we discussed and put this robot into practice. So Mako robots, the construction without segmentation. So restriction the Acetabulum was period to not follow the osteotomy into to find the three orientation point before the resection the femoral neck. And this during the surgery, sometimes the blue bubble cannot touch, so you don't need to be someone is still even in the pelvic. Double check the restriction point is accurate. This is a reaming point. The right part is because the robot thinks the cup is protruding the bone of the femur side. But they ignore that, and the robot can still show you very accurate of the cup definition and the antiversion. So the super one, medial one. This is the final implantation. So this is a patient who look at the Acetabulum side. by the assist of the robot arm, the cup can be positioned is very accurate. This other case, very similar, and they also get almost a similar leg length because this patient need to do bilateral side, other hip. This patient is very interesting, fused hip inflexible pelvic obliquity, and the left side is kind of long of the leg. So intraoperative functional coronal plane correction is not suitable for this kind of patients with spine deformity because the pelvic deformity cannot be detected. And look at the X-ray that the femur should be here, and this is the leg oriented there. The robot make a correction of these two plane. This is during surgery. The hip joint is almost fused in this case. During the surgery, it's impossible to do this hip without destroy the integrated. To save the acetabulum before bone restoration, we cut the femur neck first and then carefully ream without the femur progressively until we reach the acetabulum. We successfully take away the femur hand without taking away any ossifies on the acetabulum. So we use the checkpoint to know the restriction, to use the point to check the CT surface to see if there is accurate or not. Then before reaming, we know the transverse plan and the sagittal plan. This is the final implantation. So the plan, the inclination is 40. The result is for the anteversion is plan 20. The X-ray showed 10. We actually think it's accurate because when the patient lay on the bed, it showed the radiographic anteversion of the patient. After surgery, actually the soft tissue changed quite a lot. So the patient can lie on the bed, change of the acetabulum anteversion. This is the pre-operative. This is the 3 months after surgery. The patient can flex the femur and walk much better than 5 months ago. The other fused hip. So the results show that there was no significant difference in the preoperative data between the two groups. But either the fluoroscopic time, the Leibniz safe zone, the robot assist surgery showed a good result. The same, the safe zone ratio, the robot assist part showed good result. And we also, this our colleague published, the dominant hands-based bias did exist in manual THA, not in robotic THA. So the robot-assisted total hip arthroplasty for fused hip. In conclusion, for fused hips, Mako Robot Assist THA has the superior stability in cup positioning the manual work. The robot could eliminate the effect of surgeon's handedness. So that's all for my talk.
Yeah, that's great. It's always fun to see all the cases that you guys do, especially with the fused hips and the dysplasia. So much more diverse practice than what most people see in the United States. I do a fair amount of dysplasia compared to my colleagues, but nothing compared to you guys. Are there any cases where you have had to, I guess, not use the robot, or that it wasn't working well during the surgery and you had to abandon using robotics? Because I saw you did like 855 hip replacements. What percentage do you think were successful? Or was there like 5 of them that you couldn't do, or 10, or how, was there ever a case where you couldn't complete the surgery with the robot?
Yes, I counted the numbers all finished by the robot. Some of the cases didn't finish. I didn't count it, so I counted The number 855 is all done by the robot. I do, as you mentioned, it's a very, very brilliant question. Sometimes you have to abandon the robot surgery because you cannot eventually go through the restoration. You always like get the 0.8 to 0.9 overall accuracies cannot finish the workflow. So this is actually my question to you as the same. Sometimes you think you did a very good restoration, but eventually you cannot go through, especially for complex cases, either the osteophytes, the DDH, or fused hip. You actually, though you tried 3 or 4 times, you cannot pass the restoration part. Then you just abandon the robot.
Yeah, usually you can get it to register. Sometimes you have to change. You have to go into the menu and then change where the points are collected. And I know you know how to do that, especially in the 3.0 software that you're using, or the 3.1 that you're using. There's those first 3 points that are really important, and you have to get those in the right spot. And then you have to try to kind of tell it where its hip center is. So you take another 20 points or so within where the cup is supposed to be, and you've learned how to move those into different places for like hip fusion, because there isn't really a true hip center. But yeah, those are going to be your biggest tricks, is just to make sure the first 3 are the same, and then those hip center points are somewhere where you can reliably get to the bone. There's a different version of the software out now called 4.0, and that has been used for last year. The registration is a bit smarter and more accurate. I'm going to be curious to see if that would help with the registration on cases such as these. I do find that it is more accurate. So when you take your first 3 points, the top point, the superior point, now is moved to the iliac crest. And so by separating those points out further, the accuracy becomes much greater.
Yeah, brilliant. That's very good. And also, during the surgery I mentioned, there's 1 or 2 patients that got a very, very big inclination after the X-ray. I really relied on the patient on the robot. It showed like 40 degrees of inclination. But at the end of surgery, when you take the X-ray of the patient, it got like 48, or 1 got a 50 inclination. It's way out of the plan. I don't know why.
Yeah, that comes down to that superior point. That superior point, if you're not in the right spot, and if you have arthritis that's very hemispherical, because if you register the points too close to a hemispherical, to a hemisphere, if the osteophytes are very hemispherical around it, then it'll follow that superior point more vertical. And because if you had a perfect hemisphere, you could take 50 points in any orientation, and then the robot doesn't really know where to put it, and then it biases itself to that superior point. And that's part of the reason why I was moved to the crest. I had the same thing. I had 3 cases in my first 500 that were off by somewhere around 10 degrees, and typically more vertical. And I had that same frustration. So that's part of the reason why we have the new registration pattern now, is because of those cases. I actually sent them into Stryker, and then we figured out from the session files what happened. But yeah, all excellent points, but it's that superior landmark point. If the closer you can be and getting that accurate, the better.
Yes, as I mentioned, sometimes you got some right points, then you have to reiteration again, because sometimes it shows overall accuracy is like 0.2 or 0.3, but you got a red point. That means that area not as accurate as it showed. So as just you mentioned, you have to do it again. Then take your patient, be patient, and then you will get more accurate implantation, I think.
And the higher even on the fine registration, the higher you go up the iliac wing, the better. So if you get further away from the hip center, it's going to be more accurate. Okay.
So according to this robot assist surgery, I have some questions to you. So I really want to see you in person in the near future. I hope this year we don't have the hope. Maybe next year, I think.
Yeah.
So for your hips, do you use the lipped liner or flat liner?
So if I will use a lip liner, and then I'll put it in this posterior inferior position. So because I don't want it to impinge, but for the deep seated position, I'll use a lip liner. Just early on, I think it may be protective if you're a deep flex position, but I don't want it to impinge an extension external rotation. So I'll use a 10-degree lip. I don't use it on everybody. Once they get to larger sizes and the larger heads, I don't worry about it as much. But yeah, I frequently do put one kind of thin, flexible women. I put a lip liner in the posterior inferior position.
Yeah, that's very tricky. Why I ask this question? Because according to the Mako robot, it showed like 40 inclination or 42, 43 based on the rim of the Acetabulum. Well, then we put it like 20 degrees of anti-version. But if we put a lipped liner, that means they will change 20. But we don't know how much degrees we get, like 25 or 30 or 23, because actually the lipped was not, you cannot counting actually, because it have a high point and lower point at the rim.
Yeah, so that or you can use the lip if I guess it's hard to orient it sometimes, but if you see your transverse acetabular ligament, usually I use that as a reference for the inferior portion of the cup, and then just figure out where to dial it from there. But again, I don't use it every case, but just those the kind of thin, flexible people that I think might try to get back to yoga or get themselves in a very flexed position early in their recovery before the soft tissues heal. I think it offers some protection. The other reason to use a lip would be that you have some bony deficiency and you don't want your cup hanging out too much. And then you only want, let's say that sometimes I even see people put them anterior. So if somebody has high version, native version, they put the cup in at 35, so the anterior cup is covered. Then they'll put a 10-degree lip anteriorly for a little additional coverage. So so you don't worry about them actually having an anterior dislocation, but you want the cup to be under bone. So that's another kind of trick that you can use sometimes if somebody's deficient, particularly in the anterior wall.
Yeah, that's very interesting. Actually, when we want to publish a article, then the lip liner, you cannot demonstrate because the Mako showed a number like 20 degrees. When you put a lip liner, then it will make the editor confused how much actually the real anti-version you give actually.
Yeah, that's true.
Yeah, and then so what's your target anti-version for your average, like 20 or 25? I think if I don't use lip liner, my target may be 25.
I think that's fair. Yeah, I looked at my average. My average is 24. So there's some that I'm over and some that I put in 30. So I try to match their native anatomy. And then I also do, so on the 4.0 software, there's impingement modeling that you can run. You can actually see if there's impingement, so you can fine tune your cup position there. So I do find that, most of my cups are probably somewhere around, 42 or 43 degrees of inclination, and usually between probably 22 and 30 of anaversion.
Yeah, good point. So, nowadays, as you use robot quite a lot, so do you think the robot is the future? Because we do still have a lot of robots in the market. Actually, we have like Rosa and Mako in our hospital. We also have other 5 domestic robots in our clinical using. Some of them kind of take quite a longer time for the operating. So in the US, do you think all the surgeons will accept using the robot assist surgery, or it just kind of some kind of selection for the younger surgeons?
Yeah, I think the younger surgeons are definitely the ones who are picking it up more heavily. I think that surgeons who are my age or older who haven't adopted it yet probably won't, unless it becomes so much better. And I think that it's going to take time to prove if robotics is truly superior to manual techniques. But again, I think it's a tool that most of the fellows like and want to be able to use. So most of our fellows who are graduating are robotic users. So it's around 90%. So it's really high. But that just tells us that the future generation will try and keep pushing that way. Then the question will become, will we get other robots, at least in the U.S.? I think you have domestic robots in China. I'm not familiar with those, but in the U.S., we don't have another hip platform. Rosa's working on it, but they just total knee now. Corey for Smith and Nephew, I hear they're working on it, but they're still total knee. So I'll be curious to see when another hip robot comes out, what it looks like, and hopefully it pushes the market forward. Competition's usually a good thing. But yeah, it seems like the younger surgeons are more dependent on technology, and actually better with it too. They just pick it up quickly.
Yeah, then another question. In the US, the hospitals, like in China, the robot is kind of expensive for a smaller hospital. But in the US, does every hospital have a robot if that's possible?
Yeah, not every, but a lot of them do. We have over 1,000 robots in the United States now, which is, I never thought would happen. So it is catching on. A lot of our surgeries are actually being moved to surgery centers. So we're doing a lot more outpatient surgery. And I think COVID pushed us that direction too, just trying to get patients home the same day. Mm-hmm. And that's even more complicated because these surgery centers, they don't have as much money or profits as like a hospital does. So I don't know what's going to happen there with the cost of with these robots and like surgery centers in the United States. So that's going to hopefully, drive the price down or somehow figure out how to make these things less expensive for the institutions.
So in the future, I think the robot will become cheaper, right? Like
I think so. Yeah, I think they have to come down, and I guess right now there isn't a huge competitor to Mako that would steal a lot of their market share. So I think that if there is a competitor, particularly if it's cheaper, I think that you'll see the price of the robots drop.
And also like Mako have like the Mako the MPS, Mako product specialist. So yep. Does that charge? Is that free for the surgery?
Yeah, so there's no charge, but you can imagine it's built into the cost of the robot and cost of the implants. But yeah, there's no direct cost for the operator of the robot called the MPS. Yeah, they're a Stryker employee, and obviously you'd assume that the cost is somewhere built into the robot or implants.
Yes, and then in your opinion, according to the Mako Assist Hip and the Mako Assist Total Knee, so what do you think is more attractive for the hip? Is better, or for the knee is better?
Yeah, I like them both. I do find that the knee, you have to kind of commit to a balancing technique and an alignment technique. And so with the knee, it's harder to know because we don't really know what's best. Is it some sort of functional alignment, individualized alignment, just mechanical neutral? And so we're still trying to sort that out. So until you really commit to a balancing and alignment strategy, I think some people don't know what to do with all the numbers. Whereas the hip, I think, especially now with the impingement modeling, we're putting some of these spine parameters in, and I think it's just a little bit more straightforward on where to put them. So I think the knee, again, I think there's value in both, but the knee, we still have to come up with optimized workflows for everybody and try to figure out what alignment strategy and balancing strategy is best.
Yeah, I have the same feeling because the knee does cost more time and more complicated than hip. The hip, according to my experience, I don't have dislocation anymore, so it showed a very good result. For the total knee part, you do the total knee manually, and also by the robot. It doesn't show any benefit as the post-operative in the near 6 weeks. It didn't show any like patient feels like very similar. It just looks alignment a little bit better, I think, but I don't think it showed a great difference.
Yeah, and I think that that's fair. Again, I think we have room to grow, with our understanding of knee mechanics and balancing. And so those are things that I've been learning. And my patients, are doing better now than when I started with robotic knees back in 2016, because I think I understand balancing techniques and alignment better.
I think I should schedule a trip to your clinical and to your OR room sometime.
You're always welcome. Always welcome. It'd be great to have you. Yeah. What percentage are you doing robotically now?
For the hips
and knees? Yeah.
For hips, I think 50%. For the knees, like 1/3 of them do the robots.
Okay. Is there additional cost for the patients in China? Do they have to spend more to get a robotic surgery, or is there no cost difference for them?
Well, actually, it depends. In some region and some hospital, they charge for the robots, but the MPS part they don't charge. They only charge for the robot using. Much more expensive than the manual.
And do patients, do patients have an understanding or know what robotics is in China? Is it marketed at all, or is it more just introduced to them by the surgeon talking about it?
Yeah, actually, this is very interesting. We started to do the total hip in 2018 as the first case in China. Then we talked to the patient. We start to use the robot to do the surgery. Then they say, no, we want you to do the surgery. But now some patients start to ask for the robot-assisted surgery. It's very clear. Some patients even know Mako. He talked to me that I want to use the Mako robot to do my hip. They really, that's true. But some patients, they don't know. But some patients think the robot is like the destroyers, like the movie thing that, oh no, we don't think that's a robot. It's kind of our arm help us to do the surgery very accurate. But they think like the Boston dynamic things, it's just a real robot to do that. No, we just try to explain that to them.
Yeah, no, we get the same here, but yeah, it's interesting. But yeah, patients are more aware of it. I think just because a lot of surgeons even sometimes market that they're a robotic surgeon now. I don't, but there are surgeons that get billboards on the street that say, "Oh, come here for your robotic hip or knee surgery." So they're becoming more aware of it.
Right, great. So do you have any more comments today?
No, great job. And, I always learn a lot when you talk, and always think through how you must, think about these patients. I think we have a very similar approach, particularly dysplasia, where, we think about where the true acetabulum is and when to do a shortening osteotomy. Make sure that you look at the full femur lengths and don't just listen to the hip length number that's on the robot. So all those things that we think about, and being able to do these larger approaches, it's exciting. So yeah, I'm excited. I'm always excited to see what you're going to show, because there aren't many people in the world who are doing what you're doing.
Yeah, and you are welcome to our hospital to see this kind of patients, to give some new ideas as you are designer of the robots.
When we can travel, I'll be there. Yeah.
So at last, I would like to thank Arthroplasty Society in Asia for providing me the opportunity to participate in this seminar. And thank you, Dr. Jarbeck. We had a great nice talk. I have got a lot of inspiration from you. So everyone, this is the 4th episode of Asia Novel Seminar Season 2. So let's call it a day. Thanks for watching. Hope you all enjoy yourself. We'll see you next time. So bye-bye.
Bye. Thank you for having me.